What is the equation for volume of distribution? The equation is volume of distribution equals dose divided by plasma concentration. It is important to pay attention to the fact that volume of distribution and plasma concentration are inversely proportional. That means that when you administer a particular dose, if the vast majority of that dose stays in the plasma and the plasma concentration stays higher, your volume of distribution is going to be lower. On the other hand, for a given dose, if the plasma concentration is very low, the volume of distribution is going to be high. Drugs with a low volume of distribution are found in the blank, whereas drugs with a high VD are found in blank. Drugs with a low VD are found in the plasma. They don't distribute very well throughout the body, they stay localized in the plasma. Whereas drugs with a high volume of distribution easily sequester in the tissues. A new drug is found experimentally to have an apparent VD of 2,000 liters in a 70-kilogram adult. What is your interpretation of this data? 2,000 liters is a very large volume of distribution, regardless of the weight of the patient. The high volume of distribution means that this drug is readily sequestered in the tissues. Would hemodialysis be an effective way to eliminate this drug on overdose? Since this drug has such a very high volume of distribution, hemodialysis is not going to be very effective. Hemodialysis is most effective for drugs with a low volume of distribution, which are found primarily in the plasma. For a drug that is not secreted or reabsorbed, how would you interpret a finding that this drug's clearance is less than GFR? When the clearance is less than GFR, it means the drug is being reabsorbed from the distal tubule, while a clearance of greater than GFR means that the drug is actively secreted in the proximal tubule. For a drug with a half-life of 3 hours, given by constant IV infusion, how long will it take for this drug to reach 75% of steady state? Time to steady state depends only on the half-life of the drug, assuming that the drug is eliminated by first-order kinetics. In one half-life, you get 50% of the way to steady state. For this question, it wants to know how long will it take to reach 75% of steady state, and that takes 2 half-lives, or 6 hours, for this drug. Remember that in 4 to 5 half-lives, you reach clinical steady state. Complete the table below to compare loading dose to maintenance dose. Must know clearance to calculate. Must know volume of distribution to calculate. Usually administered as a single bolus. Most useful in emergency situations. Given to achieve steady-state plasma levels over time. You must know clearance in order to calculate a maintenance dose. It's a very important part of that equation. You must know volume of distribution to calculate loading dose. Notice that loading dose, you need volume of distribution. Maintenance dose, you need clearance. This is the key distinction between calculating these two types of doses. A loading dose is usually administered as a single bolus. It's a one-time administration most often. Loading doses are also useful in emergency situations where timing is critical. It takes 4 to 5 half-lives for a drug to reach clinical steady state, and sometimes that is a very long time if a drug has a long half-life. Maintenance doses are given to achieve steady-state plasma levels over time, thus the name maintenance dose. Your goal, to maintain plasma levels over time. When given at high therapeutic or toxic levels, identify the 3 drugs whose elimination represents a constant amount over time. Phenytoin, ethanol, and aspirin are all eliminated by zero-order kinetics at high doses. Zero-order kinetics is characterized by a constant amount of drug being lost over time. It is important to note that it is the high to the toxic levels of these drugs and not the lower levels that are associated with zero-order kinetics. Low levels of drugs like aspirin are eliminated by first-order kinetics. Complete the diagram below for drugs that are weak acids or weak bases. Weak acid or weak base drugs are going to exist in 2 forms, non-ionized or ionized. For the weak acid, the non-ionized form is RCOOH. It's the acid drug with a hydrogen attached to that carboxyl group. Since this molecule has no charge, it easily crosses membranes. The ionized form of the weak acid, RCOO-, notice with the hydrogen removed, with a positive charge, the ionized drug is better cleared. For the weak base, when the weak base is protonated, when it has a hydrogen attached to it, it's in the form of RNH3+. Positively charged ionized drugs are better cleared. The non-ionized form of the weak base, RNH2, notice once the hydrogen is removed, has no charge. Non-ionized drug easily crosses membranes. Drug number 1 is a weak acid with a pKa of 4. Drug number 2 is a weak base with a pKa of 8. When placed at the given pH, complete the table below. Drug number 1 is a weak acid. When placed at a pH of 7.4, which is higher than the drug's pKa, most of this drug will be ionized. Ionized drug does not easily cross membranes. Drug number 2 is a weak base with a pKa of 8. When placed at a pH below its pKa, in this case 7.4, it will be mostly ionized, and it will not cross membranes. When drug number 1, the weak acid, is placed at a low pH, notice a pH of 2 lower than its pKa, that's when that drug will be mostly non-ionized and easily cross membranes. When drug number 2 is placed at a high pH, 9, higher than its pKa, that's when the weak base is going to be mostly non-ionized, and that's when it will easily cross membranes. Complete the table below using acetylation, glucuronidation, or oxidation for the following statements. Reduced activity in neonates, cytochrome P450 metabolism, genetic variation may cause SLE, metabolism of chloramphenicol, metabolism of hydralazine. You see reduced activity in neonates for their ability to glucuronidate drugs. This is because neonates have low levels of the enzyme glucuronidase. Cytochrome P450 metabolism is a phase 1 reaction involving oxidation. Genotypic variation leading to SLE happens in people who are slow acetylators, so acetylation, the phase 2 reaction, is important. Metabolism of chloramphenicol is by glucuronidation. This is important to remember because neonates exposed to chloramphenicol develop gray baby syndrome because of their inability to glucuronidate the drug. Hydralazine is metabolized by acetylation. Patients who are slow acetylators might develop drug-induced SLE. Complete the table below to determine if the drug is a P450 inducer or P450 inhibitor. Phenytoin is a classic P450 inducer. Erythromycin, a very important P450 inhibitor. Grapefruit juice can inhibit P450 enzymes and has a very important drug interaction with statins, among other drugs. Phenobarbital is perhaps the most classic P450 inducer, while cimetidine is perhaps the most classic P450 inhibitor. Ritonavir, like all protease inhibitors for HIV, is a P450 inhibitor. When given to a patient on a full agonist, a competitive antagonist will have what effect on potency, what effect on efficacy? A competitive antagonist will shift the dose-response curve to the right. It will therefore decrease the potency. In other words, it takes more of the full agonist to outcompete the competitive antagonist. The curve shifts to the right, which looks like a decrease in potency. There is no effect on efficacy from a competitive antagonist. If you give enough full agonist drug, you can overcome the actions of your competitive antagonist, and you still reach 100% efficacy. Given to a patient on a full agonist, a non-competitive antagonist will have what effect on potency, what effect on efficacy? Non-competitive antagonists do not have any effect on potency. Rather, they will shift the dose-response curve downward, indicating a decrease in efficacy. This is related to the fact that non-competitive drugs either bind irreversibly to the receptor or they bind at an allosteric site. In either situation, adding more of the full agonist will not overcome the actions of a non-competitive antagonist. Your maximal effect will decrease. The most dangerous drugs have a blank therapeutic index, whereas safer drugs have a blank therapeutic index. The most dangerous drugs have a lower therapeutic index. Some drugs have a therapeutic index as low as 2. Drugs like digoxin, warfarin, theophylline, lithium are among the most dangerous that we have, whereas safer drugs have a higher therapeutic index.